wonderful case and a wonderful patient, of course. Mr. Mensing has a transtibial perforating vein, which is not so often to be seen. And there is only one publication about it. And my experience is that it is always after a lesion of the tibial bone. Because why on earth should there be blood coming out of the tibial bone? Yes. And as we will see in this case, there is really a depression in the tibial bone. And then there we see the blood coming out. So now everybody gets in place. I share my screen again with my ultrasound. This one, and move. I hope everybody sees me. Is this okay? And now we need to see, das war dieses Bein, ne? We need to see this place, please. Everybody sees the camera? Okay, the patient came with a varicose vein here on the calf and some spiders there. And if you go with the hand, you always can, here is a hole in the tibial bone. And I made an ultrasound of course, the great saphenous vein, thinking this could be a tributary of the great saphenous vein with this presentation, but everything was fine. And now I go, you see these varicose veins here? Yes?
Yes, very clear.
And suddenly there is something here happening. And if you look at it, you don't find it. I put the patient on the head down and everything, but I didn't find anything. And then I came across this thing. Let us go back and it's a longitudinal view of the bone. This is the normal view of a bone, with no injuries. And let me find the place. This is as always when you are in a film situation, you don't see it. I'm sure it is there. Did anybody of you already see a transtibial?
Yes, that's a live transmission effect.
Yes. Now here you see. Yes. Mal die Zehe am Fuß.
Yeah, wow, that's very interesting.
Stell dich mal hin. You see that suddenly the reflex disappears from somewhere. Nochmal hinstellen und Zehe heben und runterlassen.
So, Erika, this is a venous malformation.
Yes, there. No, here it is.
There you go. That's fantastic.
This is a bone defect, isn't it?
Runterlassen. And you see that there is a hole in the, I can make it bigger because it won't be deeper. You see there is the hole in the bone.
That's a very interesting.
Yes. And some of the co-authors of the paper said that these were nourishing veins, which could possibly be, but if you touch the leg, you see, I mean, here you see it. There, it could be an artifact, but there is the bone isn't. There is a hole in the bone, and you could imagine that there is a little bit of bone going inside. And what is interesting for me, drehen sich mal is Alfred Obermeier from Melk, married with a radiologist, published that these veins come from the posterior tibial vein. So if we have a look at the back, I would go down with the color here. We should find a flow. Now I'm pressing on just on the tibial, just on the tributary in the tibial point. And you see how there is a flow through the bone to the tibial vein. You understand what I mean? I'm not good in English today.
That's Erika, would you kindly confirm by putting spectral Doppler on that, is that arterial, venous, or just high flow shunt?
Okay. No, this. Wait. My friend Joseph always asks the difficult things.
Note.
Wait.
I think it is needed. This is the vein. This is vein. Yeah.
And now I press. You see, there is a the anatomy of the tibial bone is that it is drained by the tibial posterior vein. There is a tributary in the head of the tibial bone draining into the tibial vein, and where usually it is drained. Drehen Sie sich nochmal um. So today, our aim is to treat this transtibial perforating vein. And the first time I wasn't aware of the problem. Here you see it very well. Here already you see it very well. I wasn't aware of the situation that this could be transtibial. And we opened the patient because I thought it was a perforating vein. And we did, this was 20 years ago. I wasn't so used in foam sclerotherapy and so on. And we opened, and in the preparation, we discovered that this was coming out of the bone. And it was no point to close this thing. We couldn't. So you should use bone material to close that hole. And so since then, I never again touch this surgically, but always do it with foam sclerotherapy. So now we change to the recumbent situation. And I will use, because, sorry for the word, but this perforating veins are bitches. They will not be closed with one session. You have to explain to the patient that it will take 2 or 3 sessions. And I always do this with high concentrated foam sclerotherapy, even though I'm very far next to the skin, because there is no, the pressure inside the bone is just the hydrostatic column. There are no muscles protecting this vein. And it will take really 2 or 3 sessions high concentrated foam sclerotherapy to achieve the result. And in this case, I will position the probe at the opening, and I will inject in the tributary so long as to see that there is foam going in the hole. Yes? So let's try. Let's try and do it. Ich schäume, genau. Everybody hears me, sees me, and everything is fine?
Yes, we can see you and hear you very well. I'm just asking about the pathology here. Do you think this is a draining vein from the tibia out, or is the connection of vein from out going in to the bone?
No, it is from tibia going out. We can show you this. This is a good question. Sorry, I'm disappearing, and I will just take out a second, because I had a connection problem earlier, and I will need to.
If this is the draining from the tibia out, is this pathological that you should close it and it will drain somewhere else, or is it normal to have this, or is it a sign of maybe other disease like osteoporosis or some other look can manifest to this?
Yes, there are not so many cases published.
Yes,
there are not so many cases published of this, but we will show you exactly. Nehmen Sie das nochmal weg.
Okay.
Patient has been lying down. Wir müssen das auch nochmal wegnehmen. And we'll stand up. And we will show you that it's refluxing. It is obviously refluxing. Einmal bitte nochmal hinstellen. So. Where are you here? You see this?
Yes, I can see very well.
Obviously refluxing.
Yes.
and as long as he's on his feet for some time, this is the recumbence, the dependency maneuver we have been talking about in other sessions. It is very, very obviously refluxing. And why I should treat it is I'm always very reluctant to treat the vein just because it is there. But as to my experience, and I have treated 10 of these veins only go further. They go to more and more and more. And the thicker they are, the more difficult it is to treat them. And I had one patient that had a nearly ulcer in this place just next to the hole. I'm happy to healing. So thank you for coming to the question if it's refluxing or not. They are always refluxing. They are always refluxing.
Excellent.
Otherwise, you wouldn't see them. You wouldn't come across that there is a. Yes. Now I have.
And you don't want to do a CT venogram or assessing the intratibial venous pathway.
With which point? I mean, it has been done demonstrating that it is connected to the tibial vein. Would it change my treatment approach?
Yeah, that's a good question. Yeah,
no,
it wouldn't. No, it wouldn't.
So why to do something that wouldn't change my treatment approach?
My brain, yeah. I'm just interested what happened to the tibial drainage of the bone marrow inside. If this is, let us say,
as you see, it has a connection to the tibial bone through the normal feeder of the bone.
Yeah.
So, gleich gibt's einen Peaks, ich sag Bescheid, ja? I will make my foam, my 3%. This is a 3% dry foam, as I told you.
Okay.
And I will aim to give the first one. My hands are wet. This is not good. First, to focus on the hole.
It will be very interesting to see what is the sequence. Do you inject it? Do you inject the one immediately bone out, or you take out and go backward toward the bone? It will be very interesting.
So there is the hole.
Yes.
One more jelly here, a little bit more jelly here. There. And now I go a little bit further down. And inject, but it is not, it is advancing. It is coming. But it didn't, my 2 mils didn't reach the hole. They went into the distal vein. So I will have to refoam and by my next puncture go nearer to the hole. In this case, as there is no artery, I can go next to the hole. Did you see the foam expanding?
Yes, it was quite clear, yes.
Wenn ich jetzt nochmal 1% haben, oder warte, noch nicht wegwerfen, aber ziehen Sie mal in der großen nochmal 1% auf. Are you okay? Sind Sie okay? Ja? Oh, spannend. Where is it? Where is the... It is already gone. Here is the hole. It has already come here. Nevertheless, I would try and just inject here into this. Yeah, it is a painful place. There, I would just inject. And of course, I've gone a little bit past. But I want
we can see the foam going in, yeah.
Yes, a little bit more of... So now I will clean this. And I see that I have some tributaries still here around. And I will treat them with 1%. Just to... My idea is if I foam around, I stop blood from going out into the place. Liegt es nicht da noch?
Dr. Erika, with due respect, this is a perfect example, I believe, for perivascular infiltration of tumescent anesthesia, because you can shut down quite large thick vessels achieves stasis. And the thing that we need to remember is, of course, that sclerosant power is dependent on A, sclerosant concentration, B, sclerosant endothelial wall contact time, C, removal or reduction of runoff or flow. So you really want to achieve that stasis. And I think this is a perfect example of where I would love to use tumescent anesthesia, just to actually compress, seal, and close off the vessel. But of course, not always necessary.
Okay. So now you
that's
see...
That's absolutely right, yeah.
Still some tributaries here. I will inject foam.
You know, the pain tolerance in Germany is quite high to other different countries. So maybe to miss
it's my smart and lovely fingers. I'm sorry.
Oh yes, exactly. That's more important.
Exactly.
Yeah.
My experience with the patient is suffering pain because in the tibial bone, in this region, we are very, very sensitive. There are lots of nerves, and he is kind enough not to shout at me. I always think, like, if you have the water coming out somewhere and you put lots of sacks around, you will stop it better than only closing the one hole it comes out. You know what I mean? So I
know what you mean.
In this case, I always try to make all the circumferential visible veins, I treat them also, although they are already very empty of liquid.
Yeah. So at least it would decrease any recurrence. Can you do that?
Yes. Jetzt bräuchte ich nochmal Schallgel. Ganz toll hier drauf. So, and now we will have a look what happens with the... No, it stopped. Yes.
That's a very interesting case, Erika. We really would like to thank you very much for such a rare case, a rare procedure, and really a fascinating overview about general management of sclerotherapy.
Yes. Now I can't see the the hole is the hole is closed.
Yeah, it's closed. Yeah,
it's closed. So, but I tell you, I will see the patient on Tuesday.
Okay.
And I hope on Monday, tomorrow, in 2 days, and I hope that it will be closed. Normally, you see it very properly. If it is closed, it's okay. If not, I will redo just the same again with 3% on the next to the place. Yes, and genau. And I don't know the guidelines. No guideline talks about heparin in case of transtibial treatment. And
yes,
just to be sure, I give the patients low molecular heparin. In this case, I'm having tinzaparin prepared because what happened if the bone marrow would thrombose or have a reaction to the... Perhaps I have so many interesting people around in the room. What would you recommend, to give or not to give heparin?
That's a very good question to Joseph to jump in, and I will
to Joseph,
reply.
Yes.
Yes, and
well, I'd be honored to answer that question, my dear friends and colleagues.
Yes.
I would start by saying there's unfortunately absolutely no evidence to support the use of anticoagulants, unfortunately. However, if we use anecdotes and if we use clinical experience, in my experience, I would say that I would definitely evaluate the clotting risk by obviously the patient's age, clotting history, presence or absence of thrombophilia, concomitant use of certain medications, etc. So I think it's always going to be a personal thing. Unfortunately, we don't have any any evidence to support the use of anticoagulants in this situation, but also in places where we're using the thermal endovenous laser ablation of significant trunks. And I think it's important and essential not to rely on anecdote. However, having said that, no advice. In my case, I tend not to use anticoagulants readily because we need to remember there's a 1% risk of bleeding, a bleeding risk, and that could be intracranial, it could be GI, rectal, or peptic, or gastric bleeders. And I think if you're treating enough patients, 1 in 100 is a significant risk. That's my advice.
I will probably will take the hold of the other side of the stick. Definitely, there is no guideline. Definitely, there is no grade A recommendation. But what I would say is the risk factor for getting thrombosis in patient due to age, diabetes, hypertension, other factors. And I am using a thrombotic agent, which is the sclerotherapy. I would be much happier putting him on low profile of anticoagulation, either with NOACs or with antiplatelet, and follow him up for a week. Maybe this is because I'm a vascular surgeon. We see a lot of problem with clotting, but this is by no means a recommendation or by no means is a guideline. But let us say I will sleep much easier if I anticoagulate him for 2 weeks and see how it goes. This is how it goes for me.
Yes, I used to do 5 days because this is the timeline where you should not make a thrombocyte count in the patients. And you are completely right. There is no evidence, and I give this only in situations which are not described in a guideline like this. And also this patient had a prostata carcinoma. It is gone, but carcinomas are also a kind of a risk factor. And I do give prophylactic anticoagulation also if I treat very large perforating veins or recurrent. I think the next patient will have a recurrence in the groin after ligation, and he will or she will receive also this anticoagulation for 5 days because I'm treating really next to the deep vein, and I can't avoid extravasating, and I will compress the region. But I'm completely with Joseph. There is no guideline, and everybody should do like he thinks. I had in my whole life, I mean, I don't make a duplex on every patient, but I see every patient after 3 weeks. And if I have the clinical suspicion or they have pain, we make a duplex. And I remember 3 cases before 2020 and 3 cases in 21. This was the time when I didn't know that COVID vaccination was also triggering thrombosis like the COVID disease itself. And when the lockdown was, when the lockdown was taken off, I started doing all the things we didn't do in the winter. And I had, in 3 weeks, I had 3 patients with thrombosis after sclerotherapy because they had incidentally had a vaccine. So now I say, if you had COVID, you won't be treated by me the 4 weeks after. And if you're planning to have a vaccine, you won't be treated 4 weeks earlier and 4 weeks after. This is my routine, but it is, of course, also not guidelined.
Excellent. We have plenty of questions.
Yes, please, go on. Go ahead. We are changing the patient, so I will stop the...
Brilliant. Okay. So the first question from Dr. Lily Marion. Which steps do you like to prevent and minimize the skin hyperpigmentation afterwards? Which steps do you do to decrease hyperpigmentation afterwards?
I didn't show it because the patient had to leave, so we have to go on. One is we put these compressors in the tibial bone to make an extra compression on the place inside the stocking. We ask them to ambulate. We ask them to wear the stockings the first night and then 2 weeks. I use little amounts of foam and wait how it, sometimes the concomitant vein will reduce their caliber just because the inflow from the proximal vein has gone. And of course, this is not a prevention, but it is a treatment 3 weeks after making this punctures. I think that this reduces the time until they go. There are some people putting 2 injections and injecting the foam here and extracting the foam there, saying that the tissue contact is enough with 1 second. I don't know. I think that is very sophisticated. And with my around 1,000 sclerotherapies I do a year, I have 1 or 2 patients only that will come back next year saying, look at this. And they normally are red-haired and very, where the skin is very, very white. So yes. I don't know. Normally, this is gone after 3 months.
Okay.
Yes.
Yeah. Do you have any tips and tricks, Joseph, for this hyperpigmentation?
Oh, absolutely. First, I thoroughly agree with you, Dr. Erika, on immediate compression and, of course, the follow-up compression therapy. That will significantly reduce the incidence and the severity of hyperpigmentation post-sclerotherapy. But let's also keep in mind some extremely important points. Firstly, if there is residual reflux, this will invariably result in persistent or apparent hyperpigmentation following sclerotherapy, when in fact it's a failure to address. Secondly, so that's extremely important. You need to ensure that you've treated all the reflux. But secondly, more importantly, let's look at the causes for pigmentation. And in fact, there are 3 clearly distinct sources. First and foremost, tissue trauma. In response to tissue trauma, my friend and colleague, Prof. Parsi, has demonstrated that, in fact, you're getting a melanin release in response to increased melanocytic activity. So just inflammation itself will produce pigmentation, and almost all patients will get some pigmentation which is residual. Then you get into the more resistant or recalcitrant pigmentation, and that is hemosiderin breakdown. So as soon as we get a bruise, we're getting a release of red cells, and then, of course, we're getting minor stains. So we've shown as well that with sclerotherapy, you get the hyperpigmentation as a result of increased activity in melanin and melanin deposition, which is similar to what we get with sun exposure. Secondly, we're getting iron deposition and hemosiderin. Now, the third most important source will be, I beg your pardon, on the question of bruising, if, as Dr. Erika Mendoza said, if you do not release the trapped blood, you have actually left a container of red cells, which will just over time, slowly, gradually extravasate and then, of course, deposit hemosiderin. So it's essential that you treat the post-sclerotherapy trapped blood. Thirdly, finally, if the individual has either excessive iron on board or are taking iron supplements, then the logic and common sense says that you're getting hemosiderin staining as a result of that. Back to you, Professor.
Question for me, Joseph. Yes. If this is inflammation guided, shouldn't we recommend them to take any oral anti-inflammation drugs the day after?
That's an excellent suggestion, Dr. Erika. The simple answer would be we don't have any studies or proof to show that it works, but absolutely by reducing the degree of tissue injury, we're going to reduce the degree of transient hyperpigmentation. But like with your patients, Dr. Erika, as you know, the vast majority of them will get pigmentation that will completely disappear after 4 to 6 weeks. And I think when you're doing hundreds or thousands of cases per year, you quickly learn about what is helpful and what not. I might also add that I've in the past extensively used hydroquinone and bleaching agents and whatnot, but that's a complete waste of time. So please, with your residual and recalcitrant hyperpigmentation, one, check for concomitant or associated reflux or residual reflux. Two, make sure you've released all the trapped blood. Three, make sure they're not taking any iron supplementation. The only fourth bit of advice I would like to give here, if I may, particularly in Australia, is UVC exposure and sunlight exposure. Unfortunately, you can go from transient pigmentation, in many cases in my patients here in Australia, transient to actually permanent pigmentation, and that's actually caused by UVC. And again, that's where we're getting permanent damage to our melanocytic activity, and you're getting upregulation. And back to you.
This has been a very important point, Joseph, because I do this only in winter. We had a discussion in this international phlebology groups if this is important or not. I always explain my patients, you put ink on the skin and you make the tattoo with light. Yes, you put the ink and you fix it with the light. And if you have iron in the skin and put light, you will fix it like a tattoo. And you will change,
because it acts as a chromophore, and as a chromophore, it's increased the absorption and, of course, the reactivity to the same dose of UVC.
Yeah, yeah.
So I tell them not to have sun baths until 3 months or until the skin pigmentation is gone.
Excellent. So we'll go to the next question by Dr. Atilia Pascas. In case of this patient, do you recall her for clot elimination? So if you think there is clot where you done sclerotherapy, do you bring the patient to remove the clot?
We are talking about this hyperpigmentations in the vein.
Yeah.
Yes, of course. I will bring her back in 3 weeks and I will do clot expression like I do with everybody. I look at them. If there is the vein is hard, if you can palpate the vein and there are like little lentils inside, and you have to make the puncture and express it. And I do it always.
Yeah. Okay. And I know one of the candidates is very famous phleboologist from Austria, Dr. Muhammad. He's expert in using laser for skin rejuvenation. And he said he can really help a lot in post-sclerotherapy pigmentation by a lot of laser machines. So again, there is too many options to treat pigmentation with the new technology of skin rejuvenation and Q-switch laser and nano fat treatment as well. I know Dr. Muhammad is expert in that. And I got another question. Could there be a risk of deep venous thrombosis? Question by Francesca Forti. So this is question to Erika and Joseph.
Okay, well, I might take these.
Yeah,
Dr. Erika, we can't hear you, my dear.
Yes, sorry, I didn't hear the question because I was putting the patient. Would you answer, Joseph?
Yeah, the question is, could there be a risk of deep venous thrombosis with such a procedure? That's a question from Francesca Forti.
With foam sclerotherapy, always. I mean, you're putting an inflammatory agent inside a vessel, and this can produce, like everything we do to veins. Always we treat veins, we can produce a clotting, and when we give the patient a big with something else, a trauma to the vein, we can produce clotting. But the difficult thing is to handle out the risk of the clotting and how do you prevent it with other things like compression, moving, and so on.
Excellent. Would you like to add, Joseph?
I'd like to firstly thoroughly agree with Dr. Erika. This is an extremely important component. Sclerotherapy is a DVT risk-rated procedure. The baseline risk of DVT is 1 in 5,000 for the general population. Sclerotherapy increases the risk by 5 to 10-fold. Oral contraceptives increase the risk 5 to 10-fold. A long distance flight, 5 to 10-fold. When you add more than one risk, you actually multiply. So someone with varicose veins has a 5 times increased risk, and as soon as they have sclerotherapy, that goes to 50. So you need to counsel your patients, and I quote about 1 in 500 to 1 in 1,000 DVT incidence rate post sclerotherapy in my cases, and of course we need to cover that during consent.